I'm Dr. Daniel Kantor, and welcome to the MS Smackdown, also known as the NMO Smackdown, the NMO SD Smackdown, and the MOGAD Smackdown. What you're going to see here is a debate among friendly neurologists that might get a little lively, and there may be some controversy as well.
Lively? What's lively about us? Come on. It'll be civil.
What you're going to hear today is you're going to see the divisional champion be crowned. You're going to vote, and you're going to vonate. The way you vote or vonate is you vote and donate at the same time. You can set the minimum amount, I think on Facebook is to $5. And every time you vote, what you're happening is you're donating towards a nonprofit, NeuroNexus, and we're going to cure MS, cure NMO, cure NMOSD, cure MOGAD. Enough talking about trying to treat diseases. Let's actually go and cure these. Let's take it back to the physicians, to the neurologists, and to the patients where it all began. So we're going to first have the East Coast. What we're going to have is we're going to have the South versus the North. Then we're going to have a championship in Central. We already have a self-proclaimed winner, Dr. Barry Singer. And in the West, we have a self-proclaimed winner, Dr. Jeffrey Dunn at Stanford. We're going to see championships going on among whoever wins tonight, as well as those two other physicians. And there may be a wild card. You may see someone from the South. You may see Dr. Mitzi Williams come in here and try to figure out who's going to win the U.S. title. The winner of the U.S. title is going to challenge the champion from the Commonwealth. The Commonwealth countries, right now, that winner is Dr. Gavin Giovannoni, Professor Giovannoni at UCL. But I got to tell you, Professor Giovannoni, some of those Australians are creeping out from down under. They may challenge you. Some of our Canadians, I see you, Dr. Tribolucci at UBC, may challenge you. Whoever wins the Commonwealth is going to take on the American winner, whoever that may be. And so now, what's going to happen is we're not having moderation. We know moderators don't work. You, the people with multiple sclerosis, are going to send in the questions. We're going to go and debate on them. If we don't get to your question, ask it again, because we're watching this in real time. We're watching this live. And what you're going to hear is that in the red corner, hailing from Virginia, originally from Los Angeles, by way of Georgetown for her neurology residency, MS Doc, Dr. Heidi Crayton.
Woohoo! Woohoo! Team Crayton.
And I'm a little biased here, but in the blue corner, hailing from South Florida, President Emeritus of the Florida Society of Neurology, by way of Canada, by way of Cape Town, South Africa, Doogie, Dr. Daniel Kantor. Now, Dr. Crayton, you've been explained the rules. Are you ready?
I'm ready.
Let's get ready to rumble!
Nice Halloween tie there.
Thank you.
I did a little bit more Halloween though.
I want to start with a question for you while people think of their questions. You know, there's a lot of separation that seems to be happening among our community. This is one community. It's a community of people with multiple sclerosis, people with NMO, neuromyelitis optica, people with neuromyelitis optica spectrum disorder, and people with MOGAD, so with MOG antibody disease. Yet what we see is this fractionation that's happening in our communities. Why are we creating all these different communities? What's going on? What do you think, Dr. Crayton?
I think it probably stems from the fact that there are newer therapeutics, and therapeutics are becoming more specific, more targeted. And so, you know, we used to think of all of these as one issue. We always thought that they were all kind of on the spectrum of multiple sclerosis. And I think that as we've learned that there are different targets, different immunological processes going on, and there have been newer therapeutics, I think we've become a lot more fractionated because people kind of want their own little niche. And I think that it's probably a little confusing for patients, frankly. They're not quite sure who to go to, who's going to really know about their particular part of the spectrum. So, I guess it's probably good and bad. The fact that therapeutics have been created with specific targets to these other more rare conditions than multiple sclerosis is probably a good thing, though.
I gotta tell you, I think overall, the idea of fractionating the community is a bad thing. And I think it's bad because what it means is when we go to state capitals or to DC and we talk to our legislators, they say, don't come to me with 100,000 here, 450,000 there, 50,000 here. Come to me with millions of people and talk to me about the needs that people with neurological disorders have. In fact, that's why more than a decade ago here in Florida, and we followed the state of Washington by only about a year, we founded the Neuro Alliance, and they have one in California as well. And the idea is that we all have common issues. I might see somebody with multiple sclerosis who has access issues, and my colleague might see somebody with epilepsy who has access issues. So why are we having an MS day and an epilepsy day? Besides making not-for-profit executives happy, there is no reason to be splitting. Doctors are the same people who see people no matter what diagnosis they have. And I don't think anybody with MS is going to say, oh, I don't want to talk to somebody because they have something named the Vic's disease. That just seems ridiculous. The other force that's done this, frankly, has had to do with approval of medications. Right. Because of the indications that you need for the FDA, what happened is when people with multiple sclerosis came and they said, we need services, the pharmaceutical company said, okay, we have services. You could be on our drug. But when somebody with NMO came, they said, oh, we can't talk to you because you're not eligible for our drug, so we can't give you services. And so what that did is that created a need, and because of that. But you know what? It's time for us to realize it's time for us to take it back. It's time for the people with neurological diagnoses and for their physicians to come together and try to figure out how we're going to get the best possible outcomes for everybody.
Agreed. That part we actually agree on.
There we go. Dr. Crayton, have you noticed any questions coming in while we've been talking?
I actually can't see the questions.
Oh,
I only see you.
Okay. So if somebody who just put a question could put it back up right now. What we have actually going on are watch parties throughout the country. There are different patient groups coming together, watching this together. So even before we started, our donations were almost at $200. And so we'll see what happens. The voting is going to continue after this. We're going to post this online, both at Facebook as well as YouTube and all of social media. And on Sunday, November 8th at 3 p.m. Eastern, 2 p.m. Central, we're going to announce who the winner was. By the way, it's going to be me. But we'll do fair. Somebody else will do the counting, and we'll see who wins. It will be Team Crayton or Team Kantor. So another question that came in had to do with stem cells. People are starting early with these questions. Dr. Crayton, why aren't we talking about stem cells?
I think stem cells have traditionally been a very, very hot topic, have become a political topic. I think that, initially it was it was a very political topic where stem cells originated from, perhaps was part of that kind of political topic. And I think because it's also not standardized. And people are going to sometimes third world countries, they're certainly leaving the United States, and we don't always think that they're really getting proper, anything close to standard of care. And, everybody does something different. You can go to one country and have liposuction out of your belly, and then these alleged stem cells are injected into the CSF, or in a case of one of my patients, in their nose to get through their cribriform plate into their brain. It's craziness. I had another patient that had stem cells that were injected right into the front of her leg, allegedly to get right to her tibialis anterior for foot drop. I mean, craziness. Of course, she came back to me with gait problems that were really a big issue. So I think that people are so desperate for a cure. People want a cure. People with demyelinating disorders just want a cure. They're tired of hearing about stabilization. They don't want stabilization. And so the only thing that they see out there sometimes that even discusses the concept of cure is stem cells. So I think that's why people are flocking to do it.
And that's kind of like when we were talking about CCSVI
Yeah,
a couple of years ago. And I navigated
which is not
that
dead
very
yet,
carefully.
which is not dead.
But it's not that. So I'll give you two answers. And Ken, you're doing the right way. By writing your comments, you're going to be asking questions. We had a person online commenting Russia, Mexico. I don't know if they were talking about the politics of the election in a couple of days or if they were talking about stem cells. But I'll tell you, stem cells aren't where we used to be. We used to talk about it like, oh, you have to be so careful. I still think you have to be careful. But let me tell you, we are almost at prime time. I personally just wrote an investigational new drug application to the FDA, not for MS stem cells, but for another neurologic indication. We are really close. The question is, you have to figure out which stem cells. Are we talking about hematopoietic stem cells, which is most of the research? And I actually think that might be the wrong way in MS. What that's doing is that's just making new immune cells. So you're giving somebody their own cells and they're making it. So we already have medicines that reset your immune system. We already have medicines like Lemtrada, medicines like Mavenclad that kind of push down your immune system and you make a new immune system in a way. So why do we need that from stem cells when there could be other problems? What we need is actually to regenerate nerve cells. Right. And we do have stem cells that are being looked at for neurodegenerative disorders. So I would say people with MS who are interested in knowing what's going on with stem cells, you could read about what is happening in MS. The truth is what's happening outside of MS is even more exciting. We had a question come in, Dr. Crayton, and the question was, could somebody with MS who's getting worse, showing progression, not have any signs of their MRI getting worse?
You betcha. You betcha. We see that all the time. And I think it's very, it's very invalidating for patients when they tell us that they're getting worse. And we say, well, your MRI isn't really showing any change. We certainly know that there is microscopic change that's going on. There's sometimes more degenerative change. There's probably actually subclinical inflammation that we just don't pick up. With our higher powered MRIs, we certainly see more than we see in lower powered MRIs. And I really encourage patients, if they have access, to always kind of try to stay away from open MRIs, for instance. That really tells us absolutely nothing. But I think that all of us see this all the time where people just have insidious change, and it probably is, just something that's not detectable on an MRI, but just because it's not on an MRI scan doesn't mean it doesn't exist. The other confusing factor, though, is that sometimes people think that that day-to-day variation is representative of actual progression, and it's not. And people have to remember that they do have a lot of variation depending on not just temperature, barometric pressure, stress, fatigue, infection, all of those sorts of things. So I say to people, you go through 5 different incarnations in the same day. Doesn't mean that you're progressing.
So absolutely. I think there's been way too much focus on MRIs. And just the other day, I had a conversation with a very prominent women neurologists. Aren't that many of you? So let me say, there's more and more. I got to tell you now, there's probably 55% are women. But in the MS field, I think you can probably tell I'm talking about a very prominent women neurologist. And she said, well, it doesn't show dissemination in space and in time. So tell them to do another MRI for that case study. I said, but we have an opportunity to teach doctors not about MRIs, which are easy to understand. You just write down, you click on your button, order an MRI, and it's done for you magically, and somebody gets billed, and somebody has to pay, and it costs a lot of money. Why don't we use that opportunity to teach them how to do a Babinski, how to do the McArdle sign, that when somebody pushes down and they actually have weakness because they have flexion of their neck, just like when somebody has that shooting down that we see in Lermit's phenomenon. Why don't we use that opportunity to try to encourage neurologists? I'm going to say something here live that I have said privately, but I've not said publicly to people with MS. I am frustrated by the state of education in our country. I am frustrated that neurologists have allowed this to happen. We complain, oh, there used to be the greatness of our great leaders, and they taught us how to use the reflex hammer, and now doctors know it less. Whose fault is that? It's our fault. If you work at an academic center, it's your fault. If you work outside an academic center, it's your fault. We, the doctors who surround these academic centers, should demand more. we are doing a good job of making sure that doctors don't stay up during residency, don't stay awake too late at the hospital. By the way, they go home and they stay awake. They go to the beach, they go to the mall, they do other things, but they're not inside the hospital. I think that's a good thing. I don't think it was good when we were abusive, when people threw things or yelled at people. I don't think any of that was educational. So there's definitely great things that have happened. And there's definitely mistakes that have happened because of fatigue. On the other hand, we should be doing a better job of teaching our future neurologists how to be neurologists, not how to be technicians, not how to be great clickers of scribes and how to use EMRs, but we should teach them how to do what we learned best.
Exactly.
You
Agreed.
learned from great doctors in Georgetown. I learned from many of people probably know him. The doctors certainly do. I'm sure actually when you took your oral boards, do you remember a gentleman with a bald head and a bow tie named Dr. Elliot Mancall? So
I
Dr.
did not.
Mancall for years was the administrator. He was the neurologist in charge of the oral examinations that everyone was scared of and didn't want to take. Well, I was lucky enough when I was trained at Jefferson to first have as my clinic advisor the winner of the Elliot Mancall Teaching Award, Dr. David Dougherty, who unfortunately passed away several years ago from pancreatic cancer. And that's why I think people forget that doctors are people too, that things are happening in our lives as well. And then when he left the university, I talked to Dr. Mancall, and we decided that instead of me learning from the winner of the Elliot Mancall Award, I should learn from Dr. Elliot Mancall himself. And so he became my clinic advisor. And I got to tell you, in my little black bag, my red OKN strip is from Dr. Mancall. My smelling salts are from Dr. Mancall. And most importantly, what he told me, he said, Daniel, you do whatever you want in terms of these newfangled MS drugs. I will teach you how to be a clinical neurologist. He kept his promise. But that means we have responsibility, people like you and me, we have responsibility to make sure that while we're sitting in private practice, that we're not forgetting about the next generation. And there's a lot of politics involved with that. That means we have to somehow convince the university to do something. The university can't even convince the university. I mean, I was at a university for a while, and we had a committee on committees. It was kind of ridiculous.
Right.
So we're going to get back to some questions. First, a clarification. Somebody asked about stem cells. What they said is, are these stem cells coming from babies? And actually, at first, that was the controversy. At first, it came from fetal tissue, even from umbilical cord tissue, so from umbilical cord tissue. More and more, it's either autologous, coming from the person themselves, or it's allogeneic, but it's coming from like bone marrow. So it's coming not from a fetus that was aborted or anything like that. So those issues, those politics, and those religious issues and those real concerns of what happens with stem cells are no longer the problems today like they were 10, 15 years ago.
That's true. It's about consistency, though. It's really about consistency and standardization. And if we can get there, I think I agree with you. We're closer to prime time. Right now, I'd have to disagree with you. I don't think we're close to prime time because we need, what's that new pharma word? Harmonization. Love that word. Never have ever used that word until pharma.
Here's the problem.
But until there's harmonization.
Here's the problem with with talking about stem cells is you say that, but the truth is it's around the corner. People can just go to Guadalajara and they're getting things that are dangerous. And we can't allow that, but they come back and we can take care of them. So instead, what we should do is collaborate with our colleagues who are outside the United States. They wouldn't mind having collaboration with real researchers and people can look at
I'm not sure they would because I don't know that they would because it's all cash. These are cash practices.
There is great research going on at University of Mexico. There's great research going on at universities throughout the country.
But that's not typically where people go. That's not where people typically go, though. These people are not typically.
A great job of getting on Facebook and advertising and popping up ads. But that stuff is happening. You can go to the Dominican Republic. Many of the researchers who are doing real stem cell research here actually have sites outside the country as well. And so it's the same people that we all know.
Yeah.
I just think that there's a way
people
that we can do a better job.
Doing that, though.
They can still make their money. I have problems with exactly how much they're charging and what they're promising, but they can still make a reasonable amount of money. But at the same time, it could be done better.
Doogie, listen. So now these people are also, when they go away to these places and they pay this huge amount of money and they have this spa-like perfect setting and they stop smoking, They have exercise and physical therapy like 5 times a day.
So I
They
gotta tell
eat
you,
clean.
that's worth gold. That's worth
Everything
gold.
is perfect. And so then they think that all of these, these results are perfect. They come back and they kind of pick up where they left off in terms of their normal lifestyle. And then the proverbial shit happens. And sometimes their benefit is very short-lived. And I'm also against this repeated notion that you have to keep going back to get like a booster for another huge amount of money. And I just feel a lot of times it's very difficult for people to sift through those that are preying on
So you know what
desperate
the
populations.
solution? You know what that solution is? Let's get more
Harmonization.
let's get more funding and let's do more research. Let's not have just one trial in New York and one trial in Chicago and have such narrow criteria to enter them. Let's start doing it throughout. I got to tell you, there's real issues. So I've been writing these protocols. I mean, you need CGMP. You need to have good clinical manufacturing practice. It's not everyone who can create stem cells. You need actual facilities to do that. It takes money behind that. But I've got to tell you, people with MS, like other people, know people. And if somebody's interested in really doing serious stem cell research here, right now, there's a company on the block. There's a company we could buy right now to manufacture the stem cells, to do real trials where we don't just answer, well, what happens in somebody with early relapsing remitting MS? I care about those people too. Listen, everybody at one point was that person. 85% of people started out that way. Only 15% started out as primary progressive. So people start out with an early disease. But we got to think about how are we going to treat the progressive forms of this diagnosis? What are we going to do about that? And it takes money, but it doesn't take tons and tons of money. It strategically takes money, and we can do that research. We have the skill set within our field. Within MS, I'm telling you right now, we have enough of us who are not just thought leaders on MS, but are thought leaders in stem cells. We could come together. We had a pool of money. I'm telling you, we could launch a clinical trial within a year to treat progressive MS. Doesn't mean everybody can be in it, but we could launch that within a year. I promise you.
Maybe. I would say we need to really focus on getting people treated effectively early on. There's still a lot of pansies. Most neurologists are pansies. Most MS neurologists are not willing to really dive in early, really make a difference in what is, by definition, a progressive condition. We still have people that start with low efficacy, their comfort zone, and they wait till people progress before they offer them better medicine. And then if they're in a wheelchair, they get the best medicine possible. And that needs to change. And people have to get over their own fears. If you're going to take care of MS, you need to commit to being educated. You need to understand the armamentarium of tools we have, and you need to implement those tools earlier, because that, by definition, we see that it makes a big difference. If I see one more piece of data on high efficacy therapy is more effective, I think I'm going to scream. We've been talking about this. We've been bantering for 20 years about, should we start with something that's lower efficacy that I can sleep better at night? Or, should we actually make an impact on disease by starting off with really high efficacy therapy? We are not
You say that,
in unison.
Heidi, you say that, but besides those of us that we know in our circle of MS specialists, does every neurologist agree with that?
No, they don't, and that's the problem.
Exactly.
That's the problem. That's why they have people that are sitting around in scooters and wheelchairs that are young people that could have been saved. And they don't need stem cells to save them.
That failure is ours. We've relied on other people to educate our community. We should take ownership over our own community of neurologists. I mean, why am I relying on education that comes from a continuing medical education that's funded directly from pharmaceutical? Why is that where we're getting education for our doctors? It makes zero sense.
It does.
So what have we done?
It does make sense.
So let's talk about what we've done together about it, because I don't think everyone knows. Let's talk about that for a second.
We have done pharma education.
There's some very good questions about early treatment and what do you do if you don't have all the signs, you don't meet all the criteria, and also about COVID. So some really interesting questions. But let's talk about that for a second. So let's go back in time. In 2009, two really important things happened. And I think, frankly, for myself personally, these are the most important things I've done in my career, and I think I will do in my career. Which, by the way, I never admitted it online before, but that career started very early. I only admitted it because I was trying to go Dr. Boster into actually fighting me. He he got scared and you know, he got knocked out. So I have a 1-0. You only have 0. So we'll see what happens tonight. But I admitted that actually when I graduated college with a Bachelor of Arts and a Bachelor of Science Engineering from the great University of Pennsylvania, I was 19 years old. Fast forward, that makes me the youngest person. I've actually talked to the Guinness Book of World Records about it. I'm the youngest person in America who's become a board certified neurologist. I'm also the youngest person who's ever not just been the director of an academic MS center. I ran the University of Florida program in Jacksonville, took them from 700 patients to 2,000. I'm also probably one of the youngest ever who ran any kind of comprehensive program at a university. So let's just talk about our credentials in terms of that. So what happened in 2009?
Credentials mean nothing. Credentials mean nothing. We have people that are in ivory towers that don't do shit, that don't really take care of people, aren't really in the trenches, aren't really even remembering what it's like to even elicit a Babinski, that are so busy out there publishing and so research oriented that they wouldn't know progression if it smacked them in the face. So credentials, schmentials.
Let me tell you the two things in 2009 that you know well, but people with MS might not know. So in 2009, two things happened. One was I got sick and tired of traveling around the country. When I go to small towns like Baton Rouge or you go to Tuscaloosa and the doctors are holding in their pockets, in their jacket pockets, they have a CD. Because I got to tell you, patients, you know what your doctors are doing on weekends and nights? They're not playing golf and yachting. We're actually asking opinions of each other. That is the most common thing that happens. Doctors always ask for second opinions of each other. Any doctor who tells you that they have a problem with second opinions, well, you know what you say to that doctor? Bye-bye. You're not the right doctor for me. So we all ask opinions of each other. And I said, but why did I have to wait till somebody travels to town? Why not strip off all the personal health identifiers and upload it, and then we can all discuss it? There wasn't really a cloud back then. We didn't really talk about the AWS or the Amazon cloud. But I said, you know, we could upload it into the internet, and that's how we could communicate. So what we did, and you were one of the first adopters, is we started something called the Southeastern MS Consortium. I know how important SEC football is, so that's the SEMSC. That ballooned from about 300 members, ballooned after some advocacy issues that were going on. The American Academy of Neurology was telling us what to do with our patients. The government was telling us insurance, and we said enough is enough. We now are over 1,300 neurologists and some allied health professionals in the United States. We call ourselves the Medical Partnership for MS Plus. MP, the number 4, MS,
great.
plus sign. And that plus is because why are we separating NMO, NMOSD, MOGAD? It doesn't make any sense, doesn't help anybody. And then what happens is we have that organization, and we actually have some international. We started seeing doctors from India join, doctors from England, doctors from Europe, doctors from Canada. It really started spreading. So that's one thing where that is a private group that we try to help what's going on. We try to help you, the patient. We want to know about things that are going on. If you have anything that you think are systemic problems, not a problem that you're having particularly, although I could, you know, let me know. But if it's a problem that's systemic, let us know and we will try to fix it. You can just email us at info@mp4ms.com. The same year, I started going to medical conferences with a flip cam. You remember those? Flip cam no longer exists as a company, but it was very easy. It was like a little device, looked like an iPhone. There weren't iPhones back then. And you pressed the red button and it recorded. So the first video, I handed it to a prominent MS doctor named Dr. Aaron Miller. And I said, Dr. Miller, will you be my videographer? Because we are at an international conference and I want to interview your colleague, Dr. Loveland. By the way, that was an interesting conversation. And so he took the first video. And remember, 75% of neurologists are over the age of 55, predominantly men. And, you know, so shaking hands, it wasn't the greatest video ever. It wasn't the greatest technology ever, but it got the point across. In real time, I could take that, plug it into my laptop, broadcast it. After that, MS World approached me. MS World is the largest not-for-profit that's all run by people with multiple sclerosis.
Let's get to some questions.
We grew to 250,000 viewers. But this is important because what this means is that we have a way now of helping people. So let's talk about this question. Somebody said they were already diagnosed with COVID-19. So SARS-CoV-2. Should they get the flu shot? What do you think, Dr. Crayton?
You know, I have, in all honesty, I'm going to be very honest. I typically say to patients, kind of do whatever you want to do with the flu shot, whatever you would do if you didn't have MS. Most patients say, this is outside of pandemic. Most people say, you know, I'm not typically one to get the flu. I typically don't get sick. And I don't really want to have the flu shot because I just never have. And I say, then that's fine. I know that's very anti-CDC recommendation. That's anti-NMSS recommendation. This year, I think it might be more important just because it'll be hopefully make it a little bit easier to sift out flu versus COVID. We don't know if people who have had COVID can have recurrence. You know, we've had a couple of cases globally. We don't know if that's different strain. So, you know, this year I am kind of saying when people do ask, yeah, you probably should. I think the bigger question is when people are on various immunotherapies, whether or not they can actually mount a response. So I think
Oh,
that sometimes the issue from patients is it safe for me to actually get X, Y, or Z vaccination? But what they really should be asking is, do I have enough immunity to actually mount a response
wait,
to
I
make it
thought we keep
worthwhile?
seeing press releases that there's no issue here, there's no here, there's no
Right.
there, don't worry about it. Is that not true?
You know, how can we possibly move around or eliminate immune cells whose job it is to provide immunity and then tell our patients that they have full immune benefit? It's impossible. So I think that we have to really have people understand that they're not going to get full benefit from these vaccines. They can go ahead and do it, but if they're on perhaps B-cell depletion therapy, some of our other broad spectrum immunotherapies, they might not have the same immune response. It's not going to be harmful, but I think that they're probably not going to get full benefit, the benefit that they are hoping that they're going to get. What are you telling people?
Well, so you're right about two things, right? So one is
I'm only right about two
normally,
things? What?
I'll give you that. I'll give you that. And by the way, you have a ringer here who's sending me comments, and Ken, I'm watching you. But he's feeding even before you give your answer. He's kind of predicting what your answer is going to be. So I don't know what's going on there.
He's not
He's throwing
feeding
the
me.
hashtag Team Crayton. So some of the Team Cantors got
You're
to kind
just
of blow
surprised. You're just
him
surprised that
away.
I have people that actually are voting Team Crayton?
Oh yeah, you have Team Crayton voters. You definitely have. Not as many as Team Cantor, I'll tell you that. But you still have some. So there's two things. One is, do I tell everybody all the time to get a flu shot? Well, number one is I think we should come to a better consensus, not a consensus made up of people at the American Academy of Neurology or people at the FDA or people at the CDC. I think physicians with knowledge of MS, and we already have a group that has a third of all prescribers of MS drugs in this country, should just come up with a Delphi process. It's just a way of doing it. It's a modified Delphi, and we'll just come to some agreement. We may be wrong, but let's be wrong together. Let's at least have a reason. We don't, and not everything has to be filled out with science. If we wait till that, we're going to wait till like the end of time. But let's just stop guessing and let's start doing it together. So does everyone always need a flu shot? Well, some people would say that the risk of a flu shot, it's a dead vaccine, so you're not going to get the flu from it. But some people know that you actually can feel sick from it. But then the risk of getting a flu could be worse because you could actually get a relapse because of that, and that could be terrible. So overall, they're probably right. That makes sense. In years where there's not a public health reason why we think there's a problem with the flu shot, I'll give you an example. I think a year ago or 2 years ago, the flu shot was like, what, 30% effective? I mean, it was like useless. So in those years, yeah, you can skip it. But now we don't know if you're going to have, if you get sick, we don't know if you have COVID or if you have the flu. And if you have COVID, it changes everything. It changes when you can go to work. It changes when your family can go to work. It changes how people look at you. So maybe it's a good idea to just go ahead, get the flu shot.
Do it this year.
That way, if you get sick, it might still be the flu. But at least you can say, oh, I got the flu shot, so it must be COVID. And you know where to get checked out. Now, in terms of the response, I'm so glad that people like you are actually opening up your voice about it. For so long, we've been talking about, we looked at a small data set, and that small data set showed us that there's no problem. I got to tell you, what does that small data set of COVIMs tell us? It tells us that in the self-selected people who answer the questions, that being on most disease-modifying agents doesn't affect your risk of COVID. But there is one that it does. So with the B-cell depleters, it does. And we haven't been talking about that. And I think some of that has to do with pharmaceutical companies and money and follow all that. But let's leave that alone. Let's think about the science. If you push down someone's B cells, how are they supposed to get a humoral response? And how are they supposed to get a cellular response to a new antigen? There was a great paper that was just put out. Two of the people at least are actually members of MP4MS Plus. Professor Giovannoni put it on the internet, or it was already there, but he put it on his blog, on the BART's blog. And I think the first author is Dr. Amit Bar-Or, who used to be in Canada, but now at the great University of Pennsylvania, go red and blue. I was the mascot for one game, by the way.
Yeah. Why am I not surprised by that?
One game. And then you have Ed Fox is on there. And Ed Fox is finally this weekend, by the way, Dr. Fox, amazing doctor, is finally, after a year of not being able to do anything, and he had a tragic loss last year, he is now with his family, with his kids in Colorado this weekend. So I'm really happy about that. He's on that paper. And then we have other people who are members of MP4MS Plus who are actually on that paper looking at that issue of what happens in terms of B-cell depletion and what happens in terms of COVID even, what can we do in terms of vaccinations. So there's the flu vaccine where I think, in that paper specifically just about Ocrevus, I think, and all B-cell depleters maybe, but it's about different kinds of vaccines. And so it helps with the vaccines for flu a little bit, not as much as it could, but
it's
pretty
just not
well,
as much,
so you might as well go ahead.
Right.
For COVID, if there is a vaccine, and I got to tell you,
what are you going to tell people about that? Because I already have patients asking about it.
Right?
If. What are you going to tell your patients? What are you going to tell your patients?
Well, so if somebody's on Ocrevus, they should know they're taking a risk that even once there's a vaccine, they are not going to be immune to this disease. When the vaccine first comes out, it's, there's going to be early adopters. There's going to be people who take it versus people who don't. I'm not going to tell people which way I think they should do. I think that has to do with their risk assessment. Once it's out and let's say it's been safe, right? So now it's kind of there.
Are you going to take it?
Personally, how I see the world, I'm going to wait until I see some more safety data.
We're in agreement.
Because I do a very good job of really secluding myself because of this. And I'm sorry, all patients out there. We only go into the office to do, unfortunately, just to do injections. I also am board certified in headache medicine, so to do onabotulinum toxin headache injections. So things that I have to go in person. But for a neurologic exam, I think it's crucial. I haven't been able to do that. I've actually had to send most people who call me, I send them to other doctors, to other neurologists who don't have family members who they have to watch out for. I just have to really be careful. I don't want to expose it. My parents live 30 minutes from me now here in South Florida. I haven't seen them really in 9 months. So it's a terrible thing. And my father-in-law, who I'm fighting for his life in Pittsburgh right now, he just went to a skilled nursing facility and never had COVID. The day after he got there, they called me and they said, oh yeah, by the way, we have a COVID case of an employee. And I'm like, oh God. So let's just all pray and let's all pray and hope. And for Dr.
Our patients, though, I think that your experience probably is the same as mine, that our MS patients who have had COVID have had kind of varying experiences. I can tell you in my population, people have actually done really pretty well. And I think, I don't have a lot of B-cell depletion therapy patients. That's less in my population than other therapeutics. And my patients who have had COVID have actually fared pretty well. They haven't had severe complications. They haven't been intubated. They haven't required really much of anything. I have one elderly gentleman that was admitted to the hospital just to have a little nasal O2 just because of his age. He was actually a guy who does taxes, and it was the end of March, and he did a bunch of people's taxes while he was in the hospital. But I think that, in terms of COVID vaccine, you're right. People are going to make their own decision based on their risk assessment. And I think most people are probably going to wait for long-term safety data.
Yeah.
I think that, right now people want to know
somebody
about.
asked a really good question. They asked you a follow-up question. They said, you say that, but Ocrevus has really put them in remission. Are you telling people not to take Ocrevus anymore?
No, I don't. I have never been a huge B-cell depletion proponent. So the pandemic didn't change that for me. I think that Ocrevus in particular is probably overdosed. We see that they have 0 B cells. I do a blood test before every single infusion. And after that first 300, oftentimes people have nothing. So
Mm.
it's probably overdosed.
Well, yeah,
Because
because you remember when it was in development. You remember it wasn't just being developed for MS; it was being developed for lupus and rheumatoid arthritis, and those trials had to be stopped
right,
because of the infections in Southeast Asia.
right. But even,
Somebody else.
even
So
rituximab though is, wait, but like even when we typically have used other B cell depleting agents like rituximab, we usually dose by a lab value. We wait to see if the immune system is actually coming
right.
back, and then we dose. Not this kind of, blind every 6 months when people have zero B cells. So I'm not even sure exactly what I'm dosing for when people have zero B cells.
Right. So I think what's going to happen is after the dust settles, and hopefully when the dust settles, I think we as a community, the patient community as well as the physician community, we have to really look carefully without pharma, but we have to look carefully and say, are we doing the right thing with this? Because we got on this bandwagon of like long-term B cell depletion. I think Archivist slapped us in the face and gave us a reality check. So it doesn't matter what you thought beforehand, it's definitely given us a pause. And I think a lot of us, more than you think, a lot of neurologists speak to me privately and tell me that it's changed the way they think about things. They don't know what that means yet, we're not sure. But if we all sit together, we'll figure it out. You'll have an idea, someone else will have an idea. We'll figure out what's a kind of a more reasonable approach. And maybe one of the things we need to do is we need to go to the FDA and say, FDA, they need to start supplying this medication in lower doses. Because some of
Right.
the dosing has to do with what's approved. And so it is available as 300 because it's used. You could do it as 300 potentially because it's used that way, but it's not really available. There's not what's called an NDC. NDC is it just means a drug code. So some of this is just practical matters. But once again, I think we have enough knowledge and enough experts within the MS community to figure out how to do this, to go then talk to the FDA, talk to the pharmaceutical company, make sure that we have availability of these medications in ways other than what they were originally FDA approved.
Yes, but I would go way, 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 way back, and I would say people need to understand that this is the art of medicine. People need to understand, like you said, that patients are individuals. Patients have individual symptoms, individual lifestyles. We have to treat them according to their particular MS, their particular symptoms, their particular lifestyle requirements, and that is not something that is routinely done.
Right.
People kind of have their little armamentarium of what they feel safe with, and they just kind of blanketly prescribe. So we have, for instance, we'll just talk about Ocrevus as a for instance. There's this huge population of people that's all they know to write. That's all they do. So they have a lot of very inappropriate patients on it. There are inappropriate and appropriate patients on a lot of different therapies.
Right.
But I think that that's something that's really important as well, because perhaps we're setting people up for really, really bad outcomes when we put them as an inappropriate candidate on therapies that are inappropriate for them in terms of risk.
Let's shift gears a little bit. We have focused a lot on disease-modifying therapies. We didn't intend to, neither of us, I think, intended to. It's partially because of the questions, partially because of COVID and how it affects that. But other people are asking questions that have to do more with the symptoms of MS. I mean, one person actually is saying that he thinks his MS is really well controlled. And you know how he measures that it's well controlled? Not relapses, not progression, not MRI. He thinks he's doing better because he has an intrathecal Baclofen pump.
Mm-hmm.
So
and he probably
not
is.
everyone out there even knows what that is. So let me take my interviewer hat on for a second. Dr. Crayton, can you just tell us even what an intrathecal Baclofen pump is?
Sure. So Baclofen is a great anti-spasticity drug. It has been around a long, long time. We've used it. I feel like I do the best in terms of using oral Baclofen because I really titrate it and I tell people how to use it, how often, how long it lasts. They dictate how they need it prescribed. So everybody is on a different amount and it might change day to day. So for me, I give it to them as a tool and teach them how to use that tool. But it's been around a long time. People use it, but there are side effects. For a lot of people, it makes them a little loopy, makes them tired. Or when we get up to really high doses and there's a package insert max dose, and then we each have maybe our own max dose. Mine is pretty high, but once they get there, they still don't have
Dr.
great
Crayton,
control.
how high is your max dose?
200 milligrams.
Okay.
200 milligrams a day. So
okay.
if people, people either get benefit or they have bad effect. And if they get to really high dosing and they have still no benefit, then it's not useful. If they can't get the dose up because of bad effect, then that's not as not useful for them either. So the intrathecal baclofen pump can be incredibly beneficial for people where it is implanted after a trial to see if you respond to liquid baclofen around the spinal cord, which most people do. And that is placed. And it's nice because then the baclofen is just delivered where it needs to be. It's
And
not systemic. It's not in the bloodstream.
It's so
It's great.
easy to refill. It's so easy to measure. It's just,
It can be
it's so low tech.
modulated. It can
I don't
be,
have it right here,
the
but you
rate
take
can
out
be modulated.
you take out a little plastic piece of thing, you line it up, and that tells you where the hole is. You take out a needle, you put the needle in, you draw out what's left, you put in new stuff, and then you take this little computer program, which, by the way, nowadays they probably could do it on an iPhone instead of the device that Medtronic has. And you just go like that. It's just so easy, and yet neurologists aren't learning it. I think part of the problem is, that in this country, a lot of academic centers don't even have MS centers.
Right.
So a lot of people are finishing up their residency in neurology, never having really taken care of an outpatient, not an inpatient person with MS, but a regular person with multiple sclerosis. And so these are also educational opportunities, I think.
And so they have no idea, as most, I'm going to venture to use the word most MS neurologists do not know anything about symptom management. Symptom management is something that's near and dear to my heart because patients, frankly, don't always care whether they have a new spot in their MRI scan. They want their symptoms controlled so that their day-to-day living with MS is more successful. And the majority of people that call themselves MS neurologists have no idea about symptom management. They don't know anything about making somebody's day more tolerable and successful with MS, like baclofen, like the use of baclofen, like controlling people's bladder so that they can actually sit through a commute, they can sit through a meeting, a car ride, a baseball game. They don't know anything about treating fatigue. I see people who've had MS for a long time and have all of this constellation of symptoms that have never once been addressed. So then they are sometimes non-adherent with whatever therapy they're on, or they've kind of given up on what can be done for them. Even people that are progressive, people will say, I'm just getting worse and worse and worse. And how many people, I have a very large academic institution close to me in my area, not Georgetown, another one, that once they tell a patient that they are progressive, they say prior to Ocrevus, they would say, there's nothing to offer you. I have nothing to offer you.
They said diagnose and adios.
Adios, which was passé in the past. That's how things were done. But I see people that experience this particular scenario quite often, and it breaks my heart because maybe I can't do anything in terms of changing their disease course that they've had for decades and decades, but we sure as hell can make a difference in how they live every day with their MS by managing their spasticity, their bladder, their fatigue, their issues that really cause more disability than just the fact that maybe their legs don't move so well. So I would say that's where a lot of education needs to go. And it does fall in alignment. We are in agreement with your previous statement about the fact that we need to learn how to examine people, connect with people, listen to them. I'm still better at it than you because I'm a woman. So, women are just more empathetic and better listeners. But besides that, I'll give you a little bit of agreement there.
Okay.
That's what's important.
So people want to know, and Wendy wants to know, she has multiple family members and she has children who have other autoimmune disorders. And she wants to know, did she pass something on to her daughter? Did she do this to her daughter?
I would, mothers have enough guilt anyway. I would always say no. Some things we know are genetically passed down. We know that many autoimmune diseases, we don't know. We don't have any idea. For instance, MS, we know that there's some genetics that play a role. We know that there's a higher incidence of MS with identical twins than just first-degree relatives. But data has shown us that we really have, it's very, very low percentage of a child of a person with MS having MS, less than 3%. So it's chance. It's really chance. And you usually don't see it run in families. Sometimes you do, and those are really kind of scratch your head cases. But for the most part, they don't. And other autoimmune conditions sometimes don't. What tends to run in families is a general autoimmune pattern where you have people that have different.
I would go even further. It's not really even a family necessarily. It's the underlying genetics of like the environment of the the people that you come from. So if you're coming
Isn't that
from
family?
Eastern
Isn't that
Europe,
family?
from yeah, but it's not your family like people think of
No,
their
but
father,
families oftentimes
grandfather.
will have thyroid, rheumatoid
Right.
arthritis, lupus. This person has this, and then one person has MS. So no, MS isn't something that runs in the family, but they have autoimmunity that runs in the family.
Right. And so, it's not lost on me that we're, today and tomorrow are two of the holiest days for two major religions in this country, right? So today is the Sabbath. I'm sorry that we're doing these videos on the Jewish Sabbath. And next week when we announce the winner, we're on purpose doing it at 3 p.m. so that people are done with church. Also in the Central Time Zone. We're sorry about you guys in California. We don't know if you guys go to church or not. And so when you think about that, I've actually had a person once who I know who they really wanted to blame. They didn't want to blame their family. They didn't really want to blame themselves. They wanted to blame someone. They wanted to blame God, but they couldn't do that because of their religious beliefs. They were angry, so they took it out on the medical system. It was us somehow. Somehow, I don't know how we gave her lupus or MS, but it was somehow somebody else's fault, external, because she couldn't take it back to her pastor and have pastoral counseling and think about what that means. Like, why do bad things happen to good people? We don't know the answer to that. That's a age-old question. There are things that run in families, including the ability to attack your body. There are some families and some ethnicities where that happens more than others. It's actually not that uncommon at all. If Dr. Hunter was here, he would make a claim that 1% he thinks of white women of European descent probably have optic neuritis, have had optic neuritis. I mean, so it's hard to blame yourself for something. And I agree, mothers have way too much guilt. It's actually why on my birthday, I don't say, well, happy birthday to me. It's happy birthday to my mom. She's the one who carried me for 9 months. And then she had to have a C-section for
A
me to come out.
redeeming factor, Doogie.
Well, I'm a middle child. Middle children like to keep everybody happy.
I'm going to dive in here and answer this question about about I just lost it there. Talking about symptoms, talking about, yeah, we're talking about Baclofen, we're talking about fatigue management. And there's a question here from Catherine about a urologist she's seeing. She's taking Flomax for bladder retention, which is, of course, common. We see bladder issues all the time. She's asking what her chances are maybe of being catheterized. Let me just say, people are deathly afraid of being catheterized. And
Yeah.
people feel like that's associated with real badness. Let me tell you, when I see people actually start to use the catheter to completely empty their bladder and have full control of their bladder, their life changes, because all of a sudden their bladder was running their life and now they actually can run their own life and they're in control of their bladder. Bladder management is incredibly important. Most people have just spasticity. Some people have problems with actual emptying. Some people have a little bit of both. Those need to be aggressively treated. And no matter what the treatment is, no matter if it's catheterizing or whatever, get over it, because it would eventually give you freedoms that you lack. I've seen people become housebound, not enjoy activities with their family because they just don't know what's going to happen with their bladder. There are ways to gain control of your bladder, a lot of different ways. Bladder Botox, cathing, whatever, that really puts you in charge. And I think that's a really great thing. When you feel so out of control all the time with MS, to have empowerment and be empowered over your symptoms and be able to choose management, I think is incredible. So,
And I think what happens is that people sometimes, if their neurologist isn't talking to them about these things, they wonder, like, well, is this just theoretical? Like, can I actually
right.
get? And so sometimes your
Or
neurologist will be
that this
very
is their lot in
proactive.
life, that this is just kind of
Right.
what it is, what's MS.
But sometimes it'll be that your neurologist is very comfortable with these kinds of issues, with a bowel plan, with a bladder plan, with a walking plan. If your neurologist isn't, it doesn't mean they're a bad neurologist. It just means that they've decided to narrowly focus just on, kind of the structures of the nervous system itself, and not how it has an effect on actual body systems, which is crazy to me, but that happens. And so if that's the case, just work with your neurologist to find a team around you. Then if your neurologist isn't going to be the one helping you with your bladder, that's fine. But make sure you have a stellar urologist or a
Yes.
stellar gynecologist working with you. If it's a bowel problem, make sure you have a stellar gastroenterologist working with you. Make sure you have a great physical therapy team, a great occupational therapy team. You know, make sure you have all these pieces around you, because no one's going to fight for you as hard as you yourself. I was laughing a little bit while you were speaking, not because anything you said was funny, but Kathy wrote back that she wishes her son would thank her because her son was born, get this, on Labor Day. That sounds like a kind of joke my 5-year-old would make. Like what day were you born on? I was born on Labor Day.
Okay, well, I think we have to kind of get close to wrapping up because we've certainly been online for a while.
Yeah, absolutely. I know that, you know, people of older ages sometimes get fatigued by having conversations for too long. So I'll make sure to wrap this up for you, MS Doc.
Go Doogie.
So
I just
Heidi,
have other responsibilities.
so just to finish up, you know, people, it comes up all the time though. People say we're using words like relapses and progression. Can you just give your like 2-minute spiel on what is the difference and how can you tell if someone's having a relapse versus progression? I think that's just such an important thing for people to get perspective, because I don't think any of us have the exact answer, and just hearing yours I think would really help.
I think that whole term of relapsing remitting has been very confusing because people think of remission in cancer when it's gone, and people with MS certainly know it's never gone. They oftentimes have this set of baseline symptoms that's there all the time, and so then they erroneously think that they have progression. So that has to be clarified and just corrected. But people with relapses typically will report that they have a worsening either of their baseline symptoms or onset of new symptoms that last for at least 24 hours or so, not in the face of infection, not in the face of overheating. Those are all kind of pseudo flares. And then actually get better. It may not be 100% better, may be incomplete recovery, but there's stability in between those events. Whereas somebody who has progression says, I can't tell you when it started. It just is worse and worse and worse. It doesn't necessarily mean a slope like this. It can be a slope like this, and that's what people forget. People oftentimes think that progression is the worst thing, progressive MS, for instance, is the worst thing to have over relapsing MS. And I say to patients, you know what, in a heartbeat, I'd rather be a progressive patient that has a very slow, steady slope of change versus somebody with hot, inflammatory, relapsing MS where they dive deep and they have to work to get way back up to their baseline. And then every relapse, they're falling off a cliff. That's relapsing remitting MS.
Right.
And people are so afraid of progressive MS. They think the progressive MS, or that word progression, is so much worse. And we have to kind of change that mindset. I'm not about labels anyway, but I think that we need to just kind of get people to understand that there is this spectrum of MS.
Absolutely. I agree with you. I'll just tell you, the way I tell people is, if you're walking today differently than you were walking 5 years ago, like, you know, going to your son's graduation is different than going to your daughter's wedding, that might be progression. If you're walking today differently than you were 5 weeks ago, that is probably a relapse. And so I do not actually think the difference between relapse and progression has anything to do with the symptom. There are some symptoms that are more likely to be in progression, but anything can be a relapse, anything. And so it really has to do with the time course, with that slope of how fast it happens. You've been an amazing contender. You really filled in at the last minute after I TKO'd Aaron Boster, MD. And I want to congratulate you. We will see you again in a week once we count up and tally up all the votes and all the great donations. There's amazing questions going on. Let's not stop it here. Keep on asking those questions either online and social media, or if you want to ask it, you can send an email to info@mp4ms. So the number 4, so MP like medical partnership 4ms.com. Please, if you do it, let me have permission, if I can, to even take out your name, but to actually ask that question to everybody, because we would like to not just answer individual questions. We'd like to help everyone. I want to thank you so much. I want to thank the audience back home. Keep the questions coming. You guys have done an amazing job. And here's to the next week.
Happy Halloween.